Thank you very much. It is the 17th of September 2020, 3 o'clock in Delhi, and I presume in Mumbai also. I have been given the task of speaking on SGLT2 inhibitors in heart failure and in diabetes. Now, the subject is vast, and I will try my best to give you all an overview. Now, the important thing to remember is that in diabetes, most drugs which we have been using either increase the production of insulin or reduce insulin resistance, or rather increase insulin sensitivity, whether it is insulin itself, or whether it is a sulfonylurea, or metformin, or even the incretin mimetics, like the GLP receptor analogues, even they increase the production of insulin. However, now we have a new drug, a new class of drugs, which are called sodium glucose cotransporter 2 inhibitors. Now, sodium glucose cotransporter is a molecule or a tiny enzyme which ensures that the kidneys, they reabsorb glucose in the nephrons. Now, each kidney has around 3 lakh to almost 100 and maybe 18 lakhs of nephrons. The nephron, as you would remember, has a glomerulus, and then it has a proximal tubule, then a loop of Henle, then a distal tubule, and a collecting duct. Now, we will focus on the proximal tubule, and where the proximal tubes, where this enzyme, the SGLT2, reabsorbs almost 90% or more of glucose and also sodium. And by doing this, it ensures that our urine does not have any glucose. However, if the glucose goes above a threshold, that is above 180 milligram percent, then there can be some spillover. Now, the new class of medicines which inhibit this enzyme, the sodium glucose cotransporter 2 inhibitors, they prevent the reabsorption of glucose in the proximal tubules. And by doing this, they promote the excretion of glucose in the urine. And by doing this, they reduce the glucose levels in the body. Now, this was observed, and this has been confirmed in many trials. However, there was a big trial which picked up patients of diabetes, patients of type 2 diabetes, who had a glycated hemoglobin from 8 to 10%, who had diabetes for the last almost 10 years. And the crucial thing was that all these patients had some cardiovascular problem or the other. 50% of these people had myocardial infarction, 20% had peripheral arterial disease, 25% had strokes, and 2/3 had coronary artery disease. So we have a large cohort, a large quantum of patients who have diabetes plus have underlying cardiovascular problems. Now, they took more than 7,000 patients such as these and randomized them to usual therapy and empagliflozin. Now, I forgot to mention the usual SGLT2 inhibitors which are available in India freely. These are Dapagliflozin, Empagliflozin, and canagliflozin. So I will be speaking more on empagliflozin to begin with. And this big trial was called the EMPA-REG outcome trial. Now, what this showed was that in a follow-up of almost 3 years, and when more than 7,000 patients of diabetes were randomized, there were these amazing numbers which came up. The researchers found that at the end of the trial, there was a significant reduction in cardiovascular mortality by 38%. I repeat that, there was a reduction in mortality by 38%. Now, 38% is a huge number. There was also a reduction in hospitalization for heart failure by 35%. Again, a big number. The composite endpoint of cardiovascular mortality or hospitalization for heart failure was reduced by 14%, which was significant. But importantly, and this is something which has to be kept in mind, the very, very important fact which was noticed by the researchers was that there was absolutely no reduction in myocardial infarction or in stroke, which means that empagliflozin does not work via the atherosclerotic mechanism. It works by some other mechanisms. And at that point of time, the researchers did not have any clue. And so they supposed, they speculated that the mechanism of action was either because there was some diuresis, there was osmotic diuresis, there was some reduction in weight by about 2 kilograms, there was some reduction in blood pressure, again by around 2 millimeters of mercury. Because of these factors, because there was some reduction in afterload and preload, maybe because of these factors, there was an improvement in cardiovascular outcomes, and because of this, and because of these factors, there was a reduction in heart failure hospitalization and cardiovascular mortality. Another factor was brought about, and this was an improvement in the metabolic system of the cardiac myocytes. This means that empagliflozin ensured that the fuel supplied to the cardiac myocytes was superior, and this was largely in the form of ketones, beta-hydroxybutyric acid. Later on, it has been found out that this class of drug, that means empagliflozin and dapagliflozin, apart from the hemodynamic effects, they also ensure that the mitochondria dysregulation in a compromised heart or in a failing heart is improved, that there is less of oxidation toxicity, that there is less of inflammatory enzymes, and this is because they work, they enhance an enzyme or a protein called SIRT1. Now, SIRT1 is something which even I did not know of, but this is a signal of inflammation regulatory enzymes which are present in the human body. These trigger off other enzymes and other genes which ensure that the metabolism of cardiac myocytes, the cardiac cells, is improved. In fact, there are foods which are called SIRT foods and which are supposed to lessen aging or reduce the rate of aging of the human body. So I will come back. The researchers speculated, and it is still believed, we are not sure, that the improvement by empagliflozin in the Empiric trial was because of its hemodynamic effects. That was a slight reduction in blood pressure, a slight reduction in body weight, and also because it improved the metabolism of the cardiac myocytes. So, and this was done without any effect on myocardial infarction and because of any effect on strokes. There was no anti-atherosclerotic effect. The other important thing was that the side effects, that the adverse effects was same in the cohort given empagliflozin and the other cohort which did not receive empagliflozin. Now, how do I remember the adverse effects of SGLT2 inhibitors? It's by atrial fibrillation. By A, you look for amputations and acidosis. With F, you look for fungal infection and fractures. Now, the Empiric trial did show that there was increase in fungal infections in the genitalia, but these could be easily tackled. However, the prevalence or the incidence of fractures, acidosis, or amputation was the same. Even the dropout rates or the discontinuation of empagliflozin was the same as was the dropout in the placebo. So following the Empiric trial, it became clear that we had a new class of drug which not only reduced blood glucose to some extent, not to a large extent, but it had other very, very important efficacy parameters, and these were the reduction of cardiovascular mortality and the reduction in the development of heart failure. Apart from cardiovascular mortality, there was also a reduction in all-cause mortality by 32%. Now remember, these are relative reductions in clinical outcomes, but the important thing is that the composite clinical outcomes were reduced by almost 5% in absolute terms, which means that if you treat about 20 patients of diabetes over a span of 3 years, you would prevent a death or heart failure hospitalization. Now, heart failure is a very serious disease. It is largely underestimated. The figures are very grim, and these are that by the end of 5 years, despite the fact that a large number of patients of heart failure appear stable, after 5 years, almost 70% people die. The range is from 50% to 70%. That depends on which paper you study, which data you examine. But the fact is that people of heart failure with reduced ejection fraction, people with heart failure with preserved ejection fraction, both groups have a very high mortality rate after all over 5 years. Apart from mortality, the prevalence or the incidence of re-hospitalization is also very high. Almost 30 to 50% people of these patients get readmitted for heart failure. Now, heart failure is categorized as heart failure with reduced ejection fraction. That is, the ejection fraction is below 40%. That is HFrEF. And you have patients with preserved ejection fraction, wherein the ejection fraction is more than 50%. That is HFpEF. And we also have a third category of patients which have an ejection fraction ranging from 40 to 49%. These are the heart failure of mid-range ejection fraction, and which largely behave like heart failure with reduced ejection fraction. Now, the other big study, which was the Empiric Study, was published 5 years ago in the New England Journal of Medicine. I think the first author was a gentleman called Bernard Zinman. This was also presented in the European Society of Cardiology meeting of that year. Last year, there was another big study. This was now in patients of heart failure. This was called the Dapper heart failure. The SGLT2 inhibitor used was Dapagliflozin. Now we have patients only of heart failure of HFrEF, that is heart failure with reduced ejection fraction. We had around 4,400 or 4,700 patients of heart failure. The ejection fraction was below 40%. The majority had a mean ejection fraction of 31%. They were followed for almost 18 months, and it was found that the composite of mortality or heart failure hospitalization was reduced significantly by almost 25%. The reduction in heart failure hospitalization was almost 30%. Now again, these were absolute figures of almost 5%, which is a large difference in clinical outcomes. The other important thing, which is very, very important to remember, that is that in Dapper heart failure, almost 50% of patients did not have diabetes. So now we find that the SGLT2 inhibitor, which is Dapagliflozin, helps people of heart failure regardless of the fact whether they have diabetes or not. If you have diabetes, the drug works. If you do not have diabetes, once again, the drug works. There is a significant reduction in mortality and in hospitalization for heart failure. These people, again, were diabetics and non-diabetics. Now, this was published again last year in the New England Journal of Medicine. The first author was Fred McMurray, who was the principal author for the earlier trial, which was presented in 2014, which was called the Paradigm trial, which had 8,000 patients of heart failure, wherein sacubitril and valsartan showed a 20% reduction in hospitalization and mortality as opposed to the placebo group. Now, in the Dapper heart failure trial, you must remember, Dapagliflozin was given in patients above optimal, already receiving optimal medical therapy, which means that these patients of heart failure were already receiving diuretics. The number of patients was almost 95%. Almost 95% of these patients were on beta blockers. 70% of these patients were on a mineralocorticoid receptor antagonist, that is either a spironolactone or eplerenone, and almost 90% of these patients were on a RAS inhibitor, that is either an angiotensin receptor blocker or angiotensin converting enzyme inhibitor. So we have patients on optimal therapy of heart failure. Despite that fact, we have again a reduction in mortality to the tune of 18%, a relative reduction, which is pretty high, and a reduction in mortality and hospitalization for heart failure. Now, this was the Dapper heart failure trial. Now, a fortnight back, which is very recently, in Amsterdam, we had the virtual European Society of Cardiology meeting, and this meeting on the first day presented a huge trial called the Emperor Reduced trial, and this was using Empagliflozin. This again was a trial in patients of HFrEF, patients with heart failure with reduced ejection fraction. And again, these were patients who were randomized either to Empagliflozin, the dose was 10 milligrams, and the placebo group was receiving optimal medical therapy for heart failure. So Empagliflozin, over and above optimal medical therapy, showed over a period of 16 months that there was a significant reduction in clinical outcomes. The Emperor trial had 3 endpoints. The first was a combination of hospitalization for heart failure and cardiovascular mortality. And this was reduced by 25%, which was highly significant. The p-value was less than 0.001. The other secondary point was a reduction in total hospitalization, which means new hospitalizations or recurrent hospitalization for heart failure. This was reduced by 30%. Once again, this was highly significant. And the third outcome was a reduction in a decline in kidney functions. Now, I must harp on this, that the SGLT2 inhibitor, apart from helping the heart, is an excellent drug to help the kidneys. Because remember, in diabetics and in patients of heart failure, kidneys are invariably compromised in the majority of people. So to come back to the Emperor Reduced trial, the events, the decline in the GFR was reduced by almost 50% with the employment of Empagliflozin. In fact, the GFR reduced by almost 4.1 mil in the placebo group as opposed to 0.9 mil in the Empagliflozin group. The other important thing to keep in mind with the Emperor Reduced trial is that these patients were much sicker than the Dapper heart failure patients, because the ejection fraction on an average was 27% in Emperor as opposed to 31% in Dapper. The NT, the pro-NT BNPs were about 1,900 picograms in Emperor as opposed to 1,400 picograms in Dapper. So we have a higher level of pro-BNP. The third thing was that the GFR was less in the Emperor trial, about 61 ml, as opposed to 66 ml in the Dapper heart failure trial. And also it is very important to keep in mind that the use of an ARNI, that is the use of sacubitril valsartan, was only 10% in the Dapper heart failure trial, whereas in the Emperor trial, 20% of patients were on sacubitril valsartan. So we find in the Emperor Reduced trial, which included more than 3,700 patients of HFrEF, and again, half of these patients were diabetics, half of these patients were not having diabetes. There was a significant reduction in cardiovascular mortality or hospitalization for heart failure, and also a significant reduction in decline of kidney functions. But in the Emperor trial, if you just take the cardiovascular mortality, that by itself was reduced only by 8%, which was a trend towards clinical efficacy, as opposed to the Dapper heart failure trial, wherein the cardiovascular mortality was reduced by 18%. However, at the same time, excuse me, we had a meta-analysis which was published in The Lancet by Milton Packer. Milton Packer combined both the Dapper heart failure and the Emperor-reduced trials. So now we have almost 8,400 patients of HFrEF, because the two trials, the Dapper heart failure and the Emperor-reduced trials by themselves, were not powered to pick up any reduction in cardiovascular mortality. That means they were not powered to pick up significant reductions in cardiovascular mortality. So when Milton Packer did the meta-analysis of both these trials, then we find that there was a significant reduction in cardiovascular mortality of 14%. And at the same time, the composite of hospitalization and cardiovascular mortality was reduced by 25%. Also, it has been found once again that kidney functions, as assessed by a drop of GFR of almost 50%, or a doubling of creatinine, or the requirement for dialysis, or a renal mortality, was definitely reduced by almost 30 to 40% in the meta-analysis. There is also another trial called the Dapper CKD, which has been presented also in the recent Amsterdam European Society of Cardiology meeting. This is yet to be published. Here again, there were more than 4,000 patients with a mean GFR of 44 mils, and the range of the urine albumin to creatinine ranged from 200 to 5,000, and the GFR ranged from 25 mils to 70 mils. And importantly, almost 45% of people in the Dapper CKD trial had a GFR between 30 and 45. 15% of patients had a GFR between 25 and 30. Once again, it was found that the renal outcomes were reduced by as much as 40%, and the composite of cardiovascular mortality and hospitalization for heart failure was reduced by 25%. So all in all, we now have a new class of drugs which can be easily administered to the patient. There is a single tablet. It can be given once a day. The dose is in both dapagliflozin and empagliflozin is 10 milligrams. The drugs are quite safe. The only adverse effect is a slight increase in infections in genitalia. These could be bacterial infection or fungal infection, which can be easily tackled. The other adverse effects are not seen, which I've already mentioned. The big ones like amputation or fractures or acidosis are not seen. They're not really more than in the placebo group. The drugs are freely available in India in almost every town, and the drugs are relatively cheap. So now, how does one treat a patient with heart failure? There is also a very good paper which has been published in the European Heart Journal, which I must mention. What they did was they analyzed the data of the Dapper heart failure trial. They checked the background treatment of these patients and found that dapagliflozin, that means an SGLT2 inhibitor, does its work, does its good work, despite the fact that the patients are already on a beta blocker, on an ACE inhibitor, or on an MRA. Now, we must keep in mind that over the last 40 years, we have found that when a beta blocker is added to an ACE inhibitor, there is an incremental benefit. When an ACE inhibitor is added to a beta blocker, once again, we have an incremental benefit. Or when MRA, when aldactone, when spironolactone or eplerenone is added to a combination of an ACE inhibitor and a beta blocker, we once again have added incremental good effects in patients of heart failure. Similarly, this trial, which checked for background treatment in the Dapper heart failure trial, showed that although the patients were on a diuretic, although they were on a beta blocker, they were on an ACE inhibitor or an angiotensin receptor blocker, or on a mineralocorticoid receptor antagonist, there was still incremental advantage with dapagliflozin. Now, this is a very, very important thing. And now a lot of heart failure specialists are suggesting that one employs a combination of drugs straight away in patients of heart failure, because remember, the mortality in heart failure and the prevalence of destabilization in patients of HFrEF is very, very high. So the recommendation is that we begin with multiple drugs. And I remember the combination by the word SIMBA. SIMBA is that little lion in that famous Walt Disney film, The Lion King, who grows up to be the king of the pride of the lion, and in fact, who becomes the king of the jungle. Now, for SIMBA, I will take S as a sodium glucose cotransporter inhibitor. I for Ivabradine, which has also been shown to reduce the prevalence of hospitalization by heart failure and also mortality by about 20% in the SHIFT trial. M is a mineralocorticoid receptor antagonist, which could be spironolactone or eplerenone. And then we have B, that is a beta blocker. A is ARNI. ARNI would be sacubitril and valsartan. I will repeat that. You could use or remember SIMBA, SIMBA for an SGLT2 inhibitor, I for Ivabradine, M for a mineralocorticoid receptor antagonist, B for a beta blocker, and A for an ARNI, that is a sacubitril valsartan. Now, which drug would you use in the beginning? That could be your choice. You could begin with any drug, but of course, one must keep in mind that if a patient is in pulmonary edema or has fluid in the lungs, it is best not to begin with a beta blocker. In this situation, of course, we would give a diuretic and then start with an ACE inhibitor. Once the lungs have become dry, then it is safe to use a beta blocker in a small dose and then gradually titrate it up over 2 or 3 months. But once you have the ACE inhibitor and the beta blocker in the patient, there is no need to wait to begin with an MRA or with an SGLT2 inhibitor or with an ARNI. What more can I say? I think this is more or less enough. I have covered the topics in its entirety. We have a new class of medicine which is easy to use, which is reasonably safe, which reduces the HbA1c by about 0.5%, and which very importantly does not produce hypoglycemia. It improves blood glucose by improving or increasing the excretion of glucose in the kidneys. And apart from treating diabetics, it is a terrific drug to use in patients of heart failure. We have ample data. We have data on thousands of patients now. These are randomized trials which have shown excellent clinical efficacy with this new class of medication, which is the SGLT2 inhibitor. And I will finish by the sentence. Of course, there is no hard data, but there is a very, very strong suggestion by the big heart failure experts that if we use the SIMBA combination, we can reduce hospitalization and mortality in patients of HFrEF by almost 75%. Now that is a huge number, a reduction of 75% by using a combination of SIMBA in patients of HFrEF. Thank you very much for listening to me and bearing with me. I will finish here. If there are any questions, you are most welcome to ask them. Thank you very much.
So can we just wait for some time? Let us check if you have any questions, sir, please.
Of course.
Thank you, sir. So we have one question.
Yes.
Recent FDA warning has come for acute pancreatitis. Sorry, I'm sorry, sir. With SGLT2 inhibitors, what is your opinion on the same?
I think the FDA warning was for the incretin mimetic, that is not for the SGLT2 inhibitors about acute pancreatitis, and this was not seen in these trials. And I think I forgot to mention the mechanics of the improved clinical outcomes. One, of course, is the slightly improved hemodynamics. The second is the improved metabolism at the level of myocardial, of the cardiac cells. And the third is a very good paper which was published, I think, about 6 to 8 weeks back in the European Heart Journal. This was a randomized trial on which included 66 people. 66 people with diabetes and left ventricular hypertrophy, which was confirmed by a cardiac MRI, and they took the LV mass as the threshold for men was 115 grams per meter squared, and for women it was 95 grams per meter squared. And they gave dapagliflozin to these people and to these patients of diabetes with LV hypertrophy. And half were given dapagliflozin, half were not. Remember, these were 66 patients, with 33 were given dapagliflozin, 33 were not given dapagliflozin, and after a year, there was a significant reduction in left ventricular mass in the group given dapagliflozin. The mean decline or the mean reduction in the LV mass was almost 2.9 gram%, and the confidence interval was from 0.5 to 5.2 grams. So I will repeat, the mechanism of action of the SGLT2 inhibitor is improved hemodynamics, improved fuel supply to the failing myocardial cells by virtue of activating the SIRT1 enzyme, and also by the reduction of the left ventricular mass, as assessed, and this is the gold standard, as assessed by cardiac MRI.
So we have one more question. What precautions needs to be taken for subscribing SGLT2 inhibitor in patient having UTI complaints? Any advice on male or female patients?
UTI would be almost similar in males or females. I mean, normally it's an E. coli, which is the bacteria, or if it is a fungal, then the treatment is tailored to the bug involved. And I think one could, for some time, one could either pause with the empagliflozin or the dapagliflozin and then resume when the UTI is corrected. But yes, that is a good question. One must, I think, I would be careful of a patient who's admitted in a hospital with a serious condition, you know, with a pneumonia or with a heart attack. Then also I would pause with an SGLT2 inhibitor, especially if there are signs of development of metabolic acidosis. This, of course, is very, very rare. This is a very uncommon thing, but largely an SGLT2 inhibitor is known to be safe, and the only significant side effect is a urinary genitalia infection by a bacteria or by fungus.
So next question we have, after Emperor HF, which is the better one, DAPA or EMPA for a HF patient?
And that again is a very good question. No, the trial, this is called the Emperor reduced trial, and the other one was the Dapper heart failure trial. Now, when we do the meta-analysis, basically the data is coordinating. They are embracing each other. So there is no single drug, which I don't think one could say scientifically that one drug is superior to the other. Both are excellent drugs to reduce in heart failure. Both reduce cardiovascular mortality or hospitalization for heart failure, and both improve the renal outcomes. So it would be a very difficult choice. It would be, you know, I would make the choice on the availability of the medication in your geographical area.
So we have one last question. Is there any clinical trial with specific Indian patient with EMPA?
I'm not aware of any randomized trial. There may be an observational study, but I don't think there is a randomized trial with empagliflozin in Indian patients.
Sir, we have no further questions, sir. with your permission, can we conclude this session, sir?
Yes, please. Thank you very much for bearing me. Thank you very much for listening to me. Okay, bye.
Sir, on behalf of Team Lupin, we thank you very much for this presentation and for enlightening us on this topic. And a big thanks to all the participants as well for their active participation. Sir, thank you very much. Have a nice day ahead. Stay safe, sir.
Thank you very much, Rohit. Thanks. Bye-bye.